So with that, it is also my great pleasure to introduce Dr. Robert Heine, who's a distinguished Lilly scholar, and he will be talking about investing in one treatment and applying it to multiple diseases, which is another big approach that we can think about as we try to innovate in these complex diseases. So with that, it's my pleasure to hand it off to you. Thank you so much.
Oh, thank you, Grace. So this is a real pleasure and honor for me to be invited to this workshop. And I'm really pleased having the opportunity to speak about one of my great hobbies. So before joining Lilly, I was the head of the Diabetes Research Center in Amsterdam. I was very much involved in metabolic diseases and public health. So please bear with me. I really would like to provide you with some background on the topic which we will be discussing also later today. So how can we be more efficient in drug development? So investing in one treatment and can apply to multiple diseases. A simple title, but a very challenging problem to have. Next slide, please. So the root cause of what we are facing today is obesity. So even the CDC had to come with new colors to forecast the obesity rates in 10 years to come. And it's a bit horrifying to see that about half of the US population will be obese according to the cutoff point of a BMI of over 30. It's estimated 20% of all death is caused by obesity-related disorders. So it is a huge problem, a huge challenge. And I'm really still very surprised to see the complacency, the lack of sense of urgency, no really very pushing the public health measures to curb this epidemic. It really, again, shows the value of good advocacy and the inertia that has occurred when dealing with this huge problem. So such a big contrast comparing it to HIV, Ebola, or COVID. So with COVID, we could demonstrate within a year to find effective measures. So it is a conundrum that we have to deal with, but still a major one. Next slide, please. So what has happened to human evolution? Until maybe the 1950s, 60s, everything was on the right track. And the humans developed their cognition. They were innovative. They could develop fast food and could develop machines and engines to support their daily labor. So their energy expenditure went down, energy intake went up, and this resulted in obesity. Next one, please. And if you look at the graphs, can you click, please? Then you can see that in a very short period of time, the obesity rates went up. And in particular, in the low and middle income countries, and in Asia in particular, there's almost an exponential growth of people with obesity. Next, please. And this really gives rise to all the metabolic abnormalities that, next one, that is causally related to all the so-called modern diseases that threatens the health care and the status of people globally. So also in the low and middle income countries, cardiovascular disease is the leading cause of death. And diabetes, NASH, several forms of cancer, cognitive decline are all related and associated with obesity-related metabolic disorders. So we have a huge challenge ahead of us. Next, please. China gives you a very nice example of how things can go wrong in a very short period of time, because now we are talking about a 10, 15 years time span. With the quadrupling of the fast food outlets in less than 10 years, the BMI has increased in China as well. And the diabetes prevalence, which was almost non-existent when I was in medical school, has now risen to 120 million people. 25% of the global population of people with type 2 diabetes live in China. in about 10 years' time, the admissions for ischemic heart disease and the mortality rate has quadrupled, and about a quarter of the people living in Shanghai are diagnosed with fatty liver. So it is a huge problem in China, and still, and I'm really surprised to see the lack of public health measures to curb this epidemic. Next slide. So what's happening from a metabolic perspective? And this really, hopefully, gives you the background to understand how obesity or weight gain, I must say, can affect different organs at the same time. So if the person on the left top is becoming overweight, the adipose tissue is not capable anymore to store fat in a safe way. The adipocytes become apoptotic. There will be an inflammatory response. Free fatty acids starts to leak over and will be stored in different organs where the fat doesn't belong. So in the peripancreatic area, in the liver, around the heart, around the kidneys. The insulin resistance is associated with dyslipidemia, and all these factors are related to the development of hypertension, chronic kidney disease, atherosclerosis, heart failure, NASH, fibrosis, or cirrhosis, and hepatocellular carcinoma, and type 2 diabetes. So this really explains the link between these different organ-associated endpoints. Next slide, please. So how to recognize and how to identify patients who are at risk for these metabolic abnormalities? Well, already a long time ago, the so-called metabolic syndrome was proposed as one way to identify people at risk. So these are people with a waist circumference that is beyond normal, and slightly elevated fasting blood glucose, systolic blood pressure, and serum triglycerides and HDL cholesterol outside the reference values. So if you have 3 or more of those symptoms or features, then you can be diagnosed with the metabolic syndrome, and the likelihood of cardiac death is twice as high with the metabolic syndrome as compared to those people without, independent of their obesity. And there's also a dose-response relationship. So the more metabolic syndrome features you have, the higher the risk of developing an endpoint. Next slide. The problem with the waist circumference and the body mass index is that you really need to adjust it for the ethnicity. So here you can look at the 10 years diabetes risk. A 10% risk of developing diabetes in 10 years is supposedly to be a high risk. Well, that risk occurs with a BMI of around 30 in the white Caucasian population, but in the Chinese population, you only need a BMI of 24 to be at that same risk. And this truly explains also the higher susceptibility to weight gain in China, with all the consequences I just demonstrated to you, as opposed to what's happening in the white Caucasian population. So the white Caucasian population is more resistant to weight gain metabolic abnormalities as compared to Asians. Next slide. So the aspirational goal of treating obesity or weight gain associated metabolic disorders is to reinstitute metabolic health, which can be defined as the absence of the metabolic syndrome components. This will result in lowering the risk of diabetes and all the other factors I just mentioned. If you look at the clinical endpoints which you can research, if you have a drug that is supposed to improve metabolic health, then you can focus on cardiovascular disease, on chronic kidney disease, heart failure, diabetes, NASH, osteoarthritis, sleep apnea, some diabetes-related cancers, or like pancreas cancer, breast cancer, colon cancer, clinical depression, which is occurring often in patients with diabetes and obesity, impaired cognition, and polycystic ovary disease or syndrome. So these are widely separate indications. So is there a drug in diabetes or in metabolic syndrome that has really looked at multiple indications? Well, there's one that jumps to mind is the SGLT2 inhibitor, which was originally developed as a glucosuronic drug to treat diabetes. As you know, the FDA requires already since 2008 to demonstrate cardiovascular safety. So a cardiovascular endpoint trial was performed. And maybe to everyone's surprise, there was a reduction in the cardiovascular disease outcomes with the SGLT2 inhibitor as compared to the placebo. It was mainly attributable to reduction in heart failure. So then the second study was executed to demonstrate heart failure benefit in people with and without diabetes. So this was the second major outcome trial. It was also apparent from the cardiovascular endpoint trial that there may be a benefit in terms of chronic kidney disease because of the blood pressure lowering and the lowering of the glomerular pressure. So there were 3 endpoint trials now, one for diabetes, one cardiovascular endpoint trial, one trial for heart failure, and one trial for CKD. So if you multiply all these programs with maybe $700 million to $1 billion, you can imagine how expensive it is to develop drugs for these separate indications. Next slide. So if you then compare it, body weight lowering therapies with bariatric surgery, and here you can see the impact of bariatric surgery on the BMI. Well, if you look at the bariatric surgery literature, you can expect maybe 25 to 35, 40% weight reduction. So it is quite impressive. And if you then look at the outcomes, but not from randomized clinical trials, but these are just observational studies comparing a lean reference and patients who have been treated otherwise and not with bariatric surgery, then you can demonstrate that bariatric surgery indeed is associated with a better outcome, be it mortality, cardiovascular disease, and microvascular disease. But to my knowledge, there hasn't been any, and for good reasons, any randomized clinical trials comparing bariatric surgery with any other therapies. So this is a much more efficient and much more cost-effective, and still people are very much convinced by the data from bariatric surgery. Next slide. Do we need bariatric surgery like weight loss? Well, it has been clearly demonstrated that weight loss of about 10 to 15% really can deliver all the benefits you need to improve outcomes. So here you can see with a weight loss of about 10%, you can become metabolically healthy as defined by the absence of dyslipidemia, hypertension, etc. So you don't need the bariatric surgery weight loss for metabolic health. So recently, several drugs, especially in the GLP-1 class or in the dual agonist, have demonstrated weight loss that can render these major benefits. So now the challenge is, well, how are we going to develop these drugs to show metabolic health? And how can we develop these drugs such that we are still can be generate compelling data for several indications? Next slide. So this is my final slide, just to highlight what the opportunities are, the challenges, and a potential path forward. So the opportunity is quite clear. It's not an opportunity, it is a must that we are developing drugs that can treat these huge number of people who are threatened by metabolic diseases caused by weight gain. Also, the FDA has clearly expressed concern And they have stated in the obesity guidance from 10 years ago, excess body fat increases the risk of death and major comorbidities such as type 2 diabetes, hypertension, dyslipidemia. So they already recognize the need for these drugs. The challenge, obviously, is that the bar is very high. Until recently, there wasn't a single obesity drug that could deliver on the reduction of major outcomes because of the lack of potency to reduce weight by more than 10%. So only recently, a few drugs have emerged that could really deliver these weight losses. The other problem is more societal, which I struggle with, to be honest. We are apparently accepting the fact that more than half of the US population is becoming obese. Obesity, by many, is not considered to be a disease, but more as a lifestyle disorder, where patients are not taking the responsibility to adjust their intake or their energy expenditure to normalize their body weight. So it's a huge stigma on people with obesity. And I think that's something that really needs to be addressed very, very seriously. I think we really should accept obesity as a major disease, as a major risk factor for multiple serious outcomes. So I don't think it's acceptable anymore to stigmatize people with obesity. The development program for obesity drugs is really cost prohibitive. If you really need to spend almost $1 billion for each single indication, it becomes a major challenge. And probably for that reason, quite a few companies have left the metabolic field because they didn't see a way forward. So we need to be thinking about different approaches on how to do this. And the other challenge, and the last challenge I just put on this slide is, well, how do we identify the right patient for the right therapy? Not every person who is obese has a metabolic syndrome or is at the same risk. Well, there are ways to do this by looking at with cluster analysis or using the simple metabolic syndrome to identify people at particular risk. So what's the path forward? Well, can't we design studies that are more focused on total disease burden rather than on separate indications? So what do I mean with that? One patient can develop chronic kidney disease, cardiovascular disease, diabetes. So you don't need to include or to design separate studies for those endpoints, but we may want to consider a trial that looks at multiple outcomes that are relevant for this particular patient population. And as the bariatric surgery literature has demonstrated, can't we use real-world evidence and pragmatic trials to demonstrate the real-world effectiveness, not just the efficacy, but the effectiveness of novel medicines to reduce the disease burden also for registration purposes. So this is a challenge, but also an invitation to everyone to start thinking about other ways to develop drugs for this metabolic disease that really poses a huge challenge to the whole society. So with that, I really would like to return to give the word back to Dr. Colon and having a discussion on this important topic. So thanks so much for listening to this talk. Thank you.
Thank you so much. That was really fascinating when we think about the impact of all these conditions on the population and the concerning fact that it's really globally, we're seeing an even bigger impact, which really highlights the need for a broader policy discussion, which we probably can't get into today. But, you know, a lot of good food for thought here, and I'm sorry about that pun.